Welcome to today's webinar, Managing Clients' Behaviour of Concern. And your presenter today is Dr. Luke Smith, and I'm your facilitator, Nicola Graham. So we would like to acknowledge and pay respect to the traditional custodians, past and present, on whose lands we meet today. We acknowledge the deep feelings of attachment and the relationship of Aboriginal people to country, and we respect the cultural authority of the elders in each community. So just would like to briefly introduce you to Luke. I'm sure there's a lot of things that we could say, but Luke is a clinical neuropsychologist working predominantly privately in the community. He's also employed in a really interesting program as a senior neuropsychologist and clinical lead with Cabrini Health. Previous to qualifying as a neuropsychologist, Luke worked as a behavioural management consultant for Alzheimer's Australia in Victoria and South Australia. He has a particular interest in progressive neurologicals, particularly those affecting younger people or associated with movement disorders. He also has a passion for education and skills training in the progressive neurological disease and aged care sectors. So just to mention informed choice, and to hand over to you, Luke. Thank you.
Thank you so much, Nicola, and thank you to MS Australia for inviting me along to speak today. This is the first webcast I've ever completed as a speaker, although I've seen them online myself in the audience. So I'm going to give you an interesting fact to try and deter you from doing other things while you're listening to me and looking at the slides. So you know that the human brain is actually not made for multitasking. What our brain does is that it switches back and forth very, very quickly, almost milliseconds, between things. So if you are trying to multitask while you're listening to me, so if you're looking at Facebook or doing work, the chances are you're actually not going to take in as much information as if you're simply focusing on the one thing. So just to encourage you to do that as much as you can, because I know what I'm like. I'll be checking my email often while I'm doing webinars.
Luke, and I can actually see if people have brought other screens up, so I'll keep you posted
Yeah,
as we go along.
Please. We're going to keep a blacklist.
Yeah.
So just a reminder about the learning objectives for today, just so I'm trying to set the scene. So what I want to do today is try and provide more of an understanding for you to build on what you already understand of how MS can change an individual's behaviour, and particularly social cognition, which is a very interesting area. I want to try and build on your knowledge of non-pharmacological behaviour support. So what I mean by that is behaviour strategies and behaviour support that's not using medication. Particularly the types of models that are used in the neurodegenerative disease area and in MS. And I want to try and build on your learning of communication and behavioural strategies that can support the functioning of people with multiple sclerosis and other neurodegenerative diseases. What you'll notice from my slides, guys, is that I haven't got reference after reference after reference. I wanted to try and build a talk today for you that was much more practical, with take-home messages and interesting things that you can apply to your practice. There is a reading list, a reference list at the end of the talk you can use where I get most of my information, but you'll notice I'm mainly going to be using pictures, etc. So just an outline of what I want to speak about today. I'm going to give you a bit of refresher about the neuropathology associated with MS. I'm not going to go through a lot of detail, but try and explain why it is we see changes in behaviour and social cognition. I'm going to talk about different types of behaviour change. Behaviour change when it occurs in MS is actually predictable, how it can change. I'm going to talk about how people, because of MS, can have issues with social cognition and what that looks like. I'm going to try and convince you, this is my car salesman approach, of why we need to learn behaviour support. There's lots of research behind this, but I want to talk about the impact for you and your clients. I'm going to talk about behaviour support models, concepts and processes, not necessarily in huge amounts of detail, but to stimulate your interest and give you some basis with which you can learn more. And then I'm going to go through some really interesting behavioural and communication strategies. So usually when I do behaviour support workshops, I can take up to a day to do this. This is a life learning type skill that hopefully today I can ignite some of your interest, and then you can go on and learn a bit more yourself, because it can be difficult using behaviour support strategies in that it is quite a different area. So just a bit of a refresher about the neuropathology associated with MS. With the demyelination that occurs within the brain and the other pathology that occurs within people's brains, the reason why you see changes in social cognition and behaviour is because the pathology can be found in parts of the brain that are responsible for those things. So, for example, frontal lobes. Frontal lobes actually contain a high level of white matter, particularly the right frontal lobe. You might have often heard doctors or yourself say about your clients, oh, they're a bit frontal. What you're really saying is that there's changes in their behaviour. Other parts of the brain, though, that are affected by MS are also responsible for how we control our behaviour and our social cognition, and that includes the subcortical parts of our brains. So when we talk about this type of pathology for someone with MS within their brain, we often talk about what we call fronto-subcortical circuitry or fronto-subcortical areas, meaning it's both the frontal lobe and those subcortical parts of your brain that can be affected by MS, although we know that each person with MS is an individual. And by saying that, I don't mean in terms of just respecting them as an individual, but also scientifically, the way their brains are affected. So, for example, we know within MS research that it's actually not the number of plaques or the amount of pathology, it's where the pathology is. I've actually met people who have had MS for a long time who on their brain scan do have a lot of white matter change, but in terms of the changes to their behaviour, their social cognition and their cognition, it's quite minimal or not as exaggerated as you would expect it to be. So how does behaviour change? It's very difficult to actually measure behaviour change because we all have our eccentricities. I'm sure that Nicola is discovering mine today. In that we all do things that are strange and we do things that are weird. So what I really want to hammer home is I'm talking about behaviour change. Changes in your personality and behaviour from the way that it was before you became unwell. So what I want to do now is go through the different types of behaviour change. If you can try and think of maybe clients you've had where you've seen this type of behaviour change and the way that it's played out in terms of their life or in terms of your support and care for that person. You'll notice at the top that I put apathy. And the reason why I put that first is that apathy is under-recognised for people when they have progressive neurological disease. So apathy is when people have difficulties with initiation in terms of they don't want to start things. They're less interested in things. They are less motivated with things. It's important to recognise that with MS, I'm going to talk about that in the next few slides, that your risk of depression is much higher when you have MS. But for some people with MS, they can show apathy, so a lack of motivation, but they're not sad. They're not miserable. They're not feeling hopeless. It's almost like they have the apathy without the depression, because apathy is a part of depression. Anyone who's listening or watching this webcast, if you've been depressed or sad before, you know you're not very motivated. It's important to recognise as though that apathy can occur for people with MS without sadness. And what you'll find is that often medical professionals might try and treat the depression with antidepressants, but you soon realise that they're not really sad. Apathy is a bit of a hidden disability in that, particularly for people with MS, when it's more severe and they might be in supported care, these are the types, people with this type of behaviour change is what staff love, because they sit in the corner and they don't get in your face, they're not demanding. But when you ask them if they want to have a shower, or they need to take their medication, or do they want to go out with their family for a visit, they say no. And it's an illogical no, it doesn't really make sense. Disinhibition and impulsivity is where it's almost like the filter in your brain starts to go. We all think things that are inappropriate. I can say this because I can't see you and I'm sitting behind a computer screen. But I used to work as a checkout person at a supermarket. And often people would come through with their kids. You know, the kids might be a little bit overweight. Maybe they've learned to swear at the age of 5. And the mum or the dad are putting on the checkout Mars bars and chips and pies and Coca-Cola, nothing healthy. And in my head, I'm thinking, do you really need to buy that? Shouldn't you be buying healthy food? Now, I never said that, otherwise I would have lost my job. And fortunately, most of the time my frontal lobe works well. But if someone with MS has this type of behaviour change, they might start telling people all those inappropriate things that are in their head. It's also what they do. So not just the sort of that filter about between what we're thinking and what we say, it's also what we do. In terms of people can do things impulsively, like impulsively spend money on things. I once worked with a young guy with MS who, despite having a dirt bike, then bought himself 2 more dirt bikes. And in the past, before developing MS, he was actually someone who's quite frugal. So he was starting to lack that filter with his decision making. Rigidity and inflexibility, in my experience in working with people with MS, can often be more distressing in terms of a behaviour than something like aggression, which goes against what some of the research tells us for other progressive neurological diseases. You will know, you can think of clients with MS where they show this behaviour, where they don't seem to be able to see your point of view. You might consider them to be unreasonable, and they really are very routine fixed. I remember there was a female client with MS I was working with where trying to position her in a wheelchair, particularly for the physios and OTs, was hell, because she was so rigid about how she should be positioned and where she wanted her legs to be that it would take them hours to find the right position for her. It also means that for people with MS, particularly when their disease has progressed a bit more, is that they may have difficulty adapting to new environments, to new routines, to new people, for example. So it's important to keep that in mind, because what we often interpret as stubbornness or someone being unreasonable is actually neurobehavioural change. Irritability, agitation and aggression is the next one. It's a bit of a scale. People can be irritable in terms of they might be a bit grumpy and a bit on edge. Agitation is when they start to show it, usually physically, and aggression is really serious when people can be physically or verbally aggressive. It's important to recognise, and I know I'm preaching to the converted, that most people with MS actually don't really show a lot of aggression. And in fact, depending on the research you look at, where there's some readings at the end of this talk, these different kinds of behaviour change. The percentages of how many people show this change depending on the research. Some research says that disinhibition and impulsivity is quite low, others say it's high. But when you see aggression, this is having a major impact for that person, for their family, for you. We break down aggression into two different areas. The first is verbal aggression. This can be screaming, yelling, swearing, or threats. Physical aggression is not just things like hitting or kicking or biting or spitting. It's also when people destroy property. So if a client of yours is becoming aggressive and decides to pick up their iPad and smash it on the ground, that's physical aggression. It may not be directed towards you, but it's directed towards an object. Euphoria is a really interesting phenomenon that can occur for people with MS. Euphoria is where they're almost too happy. They have these really exaggerated and heightened feels of happiness, which means that often their reality is quite different to the reality that we're all seeing. Excuse me. The last one is impaired insight. To sort of demonstrate what impaired insight is, I'm going to get you to use your executive functioning, which is a cognitive ability, to solve a riddle for me. If you break your leg, what part of your body tells you that you're in pain? It's your brain. It's not your leg. If you were thinking leg, that's okay. There's usually a few people. But it's your brain that tells you that you're in pain and that you might have a broken leg. So when you go to the doctor and the doctor says, look, you've broken your leg and you need to be in a plaster cast for 6 to 8 weeks and you're not allowed to drive your car, you need to stay off it. The thing that allows you to understand that information from the doctor, follow it, and relate it back to your broken leg, you guessed it, is your brain. So here's the riddle. What part of your body tells you there's something wrong with your brain? And that's the conundrum of insight. For people with MS, it may be that the disease that's in their brain means that their brain doesn't allow them to understand the disease in their brain. It's a bit of a cruel irony in some ways. But why this is important for us is because often we rely on insight. We rely on the fact that I am here, my name's Luke, I'm a neuropsychologist, I'm here to do a cognitive and behavioural assessment because you've been diagnosed with MS. As a result of the MS, your family are a bit stressed and worried about you, blah, 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 blah. At this point, I'm speaking Swahili to them. Because in the same way that I believe that I'm wearing a white shirt, they believe that either there's nothing wrong with them, or even if they do understand the fact that they have MS and it means that they're not able to walk as well, they may not be able to know then generalise how that affects their life, how much care they need, how much therapy they need. So you can see behaviour can change in many different ways. It's predictable, and depending on the research you read, some are more common than others. But something else that plays into behaviour is also what we call mental health symptoms, sometimes also called psychiatric symptoms. I'm not going to go into these in detail today because it's not necessarily the focus of the talk, but it's important to keep in mind. Emotional ability is incredibly common in MS. And what it means is that people's emotions vary much more than yours and I do. As soon as you have a brain condition, particularly a white matter disease condition like MS, your functioning, your emotions, everything fluctuates so much more than it would for someone without MS. So emotional functioning can go up and down. Often carers or families will say they're much moodier than they used to be. Depression is much more common for people with MS, not just because people are diagnosed with an illness which is very confronting, that is something that over time will affect their function and independence, but also the parts of the brain affected by MS, you guessed it, are often the parts of the brain that help to control our mood. Anxiety is on that same spectrum. I also wanted to mention delusions and hallucinations. It's something we don't often talk about, but a delusion is where someone has a false idea or a false thought, such as they believe that when the nurses are giving them medication, the nurses are trying to poison them. Hallucinations is where you see or hear or taste or touch or smell something that isn't real. Now, it's important to recognize that with delusions and hallucinations, that is brain dysfunction. It's not something that people are doing on purpose. And yet in the 70s, most nurses were taught to use something called reality testing, which is basically where you hammer home someone's reality to them. It actually doesn't work, because unless you've cured their MS magically, the delusions and hallucinations will remain. But it's important to recognize these things when we're looking at behavior. Social cognition, which is what I'm about to talk about next, is a fascinating area, something I'm very interested by. It actually comes from the autism research that's now occurring around the world. So if anyone in the audience works with people with autism or knows someone with autism, one of the major issues that people with autism have is socializing, is social skills. Now, ironically, this area that I'm about to talk about, most of the research came from the UK, from someone named Professor Baron Cohen. For those people in the audience, can you think of anyone else with the last name Baron Cohen?
I can think of his outfit.
That's right. So ironically, Sacha Baron Cohen, who plays Ali G, who plays Borat, who plays the dictator, that's his brother. I find it ironically hilarious, given that you could argue that all those characters have very poor social cognition and poor social skills. Maybe that was the early influence for Professor Baron Cohen to do the work. But importantly, autism is actually elements of it are a frontal lobe condition. And what I'm going to go through now is these different parts of social cognition and how they can change for your clients. So the first one is that for people with MS, some people, and often quite early in the illness, obviously depending on what type of MS they have, they will have difficulty reading the facial emotions of other people. Our face is the largest instrument with which we express emotion. And over time, we think that in the evolution of the human species, we have developed shortcuts in which we can socialize and read other people's emotions. We think this is because humans are a social animal. We live in social groups. And in fact, when people don't live in social groups, we pathologize them. We use names like recluse and shut out and hermit. So over time, our brains have developed these shortcuts, or people who had these shortcuts had an evolutionary advantage. For people with MS, when they are reading the emotions of other people on their faces, they can have difficulty with negative emotions. So by negative emotions, I mean things like surprise, disgust, sadness, anger. Often they won't recognize the emotion, or they'll confuse it. You can imagine what this does for relationships, particularly for family relationships, in that if we rely on these nuances of these almost automatic ways of socializing, when they start to change for people with MS can be accused of being cold, unempathetic, all these types of descriptions. But often it's the changes within their brain, particularly the mirror neurons, which are in the frontal lobe. There's one emotion that generally isn't affected, and that's happiness, which gives you your first behavior strategy for the day. If you can show sincere happiness to people, often you're already building rapport with them before you've said anything. And the way that I build happiness is by doing what I call a 5-second check-in. It's where I close my eyes, I lower my arms, I shrug off all the busyness and stress I've had already in my day, and I think of something happy, something really happy. And what that does is it generates a smile on my face, a real smile that your client with MS is more likely than not going to understand and often smile back. You have to be really careful, and I'm lucky with the magic of technology. I can show you how not to smile. That's when you try to smile without thinking of happiness. You smile like this. So you smile without your eyes. It's kind of creepy, actually. So that's why it's important to think of something happy, because that generates from your brain happiness on your face. But it's more than just recognizing emotions. What you and I do when we're reading someone's emotions is we then also, without even thinking about it, automatically try and read their mind. So for example, right now, if I was speaking and Nicola's looking at me, which fortunately she's not, and she's showing an angry face to me, I don't just leave it at that. I then think, why is Nicola angry? And I will guess. My guess is probably going to be whatever I'm talking about is making her angry, so it's inappropriate. So it's not just recognizing emotions, it's then also we use that information then to try and guess what people are thinking. Why that's so important, why it is so crucial, is that if I read Nicola's face as being angry and I think it's because what I'm saying, what I'm going to do is I'm going to change my behavior. I'm going to change what I'm saying or what I'm doing. So for people with MS, if they have this difficulty, you might be becoming angry and angrier, but they're not changing their behavior because they're not able to put themselves in your shoes. They really can't read your mind very well. The next part of social cognition, which is absolutely fascinating, is that some people with MS will have difficulty understanding the emotional tone of your voice. We call it prosody or prosody, depending on how you pronounce it. But basically it means that when you're using things like wit and sarcasm, it's the emotional content, the emotional tone of your voice that gives away whether it's being sarcastic. I remember many years ago when I was in Canada touring around, I was staying with some friends who were Canadian, and I rang back home. Now, Canadians and Americans, in my experience, and I apologise if there are any Canadians or Americans in the audience, but there are cultural differences in the way that we use humour, and particularly when we use wit and sarcasm. And I would be calling home to my friends, and as you'll know that many Australians give their Australian friends somewhat offensive nicknames that I'm not going to talk about today, but I called my friend by this offensive nickname that I'd always known them as, and they thought that I didn't like my friend over the phone. But if they picked up on the emotional content of my voice, they would have realised I was being sarcastic, and this was actually an affectionate thing. For people with MS, they may not pick that up from you. And the challenge for us is we often use sarcasm and wit to build rapport. So I might say to a science, it's a beautiful day, and they say, no, it's not, it's raining. And straight away I've had a breakdown in my communication. So I need to be aware of the way we use wit and sarcasm, because often for people with MS, they may not understand it as well as we think they should. But this change in social functioning and social cognition goes both ways. So it's not just the way that people with MS interpret our facial emotions, what we're thinking, and the content of our voice. It goes the other way. So research tells us that for people with MS, is that the way that they express emotions on their face can change, because the thing that's responsible is your brain. And research tells us that we can actually misinterpret people's facial emotions when they have MS. And usually what occurs in this space is that we overestimate how introverted or shy they are, because we see a lack of emotion as being shy, introverted, or sometimes aggression as well. There's also a symptom that can occur for people with MS, which sometimes is called pseudobulbar affect, but you might know as emotional lability, although we generally use pseudobulbar affect. That's when people can experience what doctors like to call, it's a funny term, pathological crying or laughing. What that is excessive crying, excessive laughing. One of the key things that people often tell me is that when they're watching a romantic comedy, you know, at the end when all of us have a slight tear because the girl got the boy, and we look around to make sure no one knows that we're crying. For someone with MS with this symptom, they might be excessively crying, and everyone in the room's like, why are they crying so much? Or they might be excessively laughing at a joke. I once had a husband tell me, after a doctor successfully treated this condition, said, oh, would you mind taking away the medication because I'm no longer the funniest man in the world. Mm-hmm. So this is a really strange environment for people with MS to be in, because what their face and their emotions are showing, it doesn't actually reflect how they're feeling internally. And this can be another cause of breakdown in social communication. I warn you, I'm about to go into car salesman mode. What I want to show you is why we need to learn behaviour support. And maybe at this point we could put another poll into the field, Nicola. What do you think? There was a poll around how many people I think have had experience or training in behaviour management in their careers.
Okay.
Do we have that one?
We've got what is the most common change? what behaviour of concern is the greatest.
Let's go to the third one. Let's go to the training one. So what I'd like to do, what I'd like to do before I get into this area, guys, is know how much training or experience you have in behaviour support. So I think Nicola's going to put the poll in the field, and before I go to the next section.
Great. So the poll is, what level of training have you received in non-pharmacological behaviour support? None, very little, an average amount, more than average, or a very high level. And if you could just select one, that would be fantastic. And I can see that 60% of you have voted already, so that's fantastic. We'll just give you a little bit longer to vote, and that's great. Okay. So most people have voted now. Thank you very much for that. We'll close that and just share the results from that. So 7% none, 50% very little, 36% an average amount, 7% more than average, and nobody has a very high level.
That's really interesting, guys. And can I say it's not uncommon? So I'm not putting this poll out to make you feel bad. It's more that behaviour is sometimes the hidden symptom, the hidden disability. And yet what I'm about to tell you is quite striking. So it's not unusual, like in that poll, that the vast majority of people have had either average or less than what they consider average training. The reason why we are not good at behaviour management often, unless we have training, in the same way that over our evolution we are wired with these social cognition skills, we are wired with other biases and shortcuts within our brain which make it inaccurate in the way we judge other people's behaviour, which I'm going to talk about now. So the first one is what we call a self-fulfilling prophecy. And what it is that when we make a judgment about someone, we do it very quickly. And then what our brain does is that it only looks for information to support our ideas. And it filters out all the other relevant information which may disprove our ideas. So that's called a self-fulfilling prophecy. So for example, you might meet a client with MS for the first time, and on that day, because it was a hot day, because they were out of their routine and they were tired and you are new, they are agitated towards you. For whatever reason, you develop a belief that they're just that kind of person, that they're just an agitated person. No matter what you do, it's not going to change. Once you make that kind of idea, and that happens very quickly, literally within seconds, it's very hard to shift you. It's very hard to shift you away from that idea, despite the fact that the family and other clinicians might be saying to you, look, they're really fatigued, it's been a hot day, they do have trouble with new people. It's very hard for us to change our minds, which is really interesting. The next one's called the halo effect, which you'll see the halo above the brain. I find this really fascinating. It's where we think that people are good looking, or one trait they have is good. We think all of them is good. This is an honest thing we find from research. You have two occupational therapists go for the same job at a job interview. They both have the same CV and they both interview just as well. One occupational therapist is considered better than the other occupational therapist. Who gets the job? The better looking occupational therapist. Because we think because they're good looking, that all of them is good. And it can be the same for personality traits. It's why we get so shocked when a celebrity cheats on their wife or husband. You know, they're perfect people. How could they do that? The next one is called groupthink. And what this is a strongly held bias we have where we think everyone thinks like us. So I can tell you that if I am aggressive towards anybody, I'm either at the football or I don't like you. And I'm not a very aggressive person, but we all sometimes can be aggressive. So if someone with MS is aggressive towards me, my first thought is going to be they don't like me or they hate me. My first thought is rarely going to be, unless I train myself, they have MS and it's likely that this MS has caused a change in their behaviour which is causing aggression. So it's really interesting. What training tries to do is not just equip you with skills, but tries to get you to think differently or to not think with your biases about the way people behave. Going back to that poll again, is that out of all the symptoms you find with any progressive neurological disease, and this does ring true for MS, is that behaviours of concern, behaviour change is often the largest cause of distress for the person with MS, for their families, and for you, often above and beyond other symptoms of MS, such as changes in cognitive function, changes in mobility, changes in continence, changes in all sorts of things. And the reason why is because we personalize behavior. We take it personally, which causes us emotional distress. And it's also the interface in which we work with our clients. We behave with them, they behave with us. But behaviours of concern in the progressive neurological disease field is directly linked with things like safety risks, stress for professionals, unstable accommodation, financial burden, carer burden. All of these things are related to behaviours of concern. I still find it interesting based on the fact that so many of us don't have fantastic training in managing behaviours of concern. The difficulty with behaviour support is that it's not a hard science. It's not like chemistry, whereas if you put chemical A with chemical B under certain conditions, you get chemical C. As soon as humans are interacting with humans, all of these biases and complications come in. So over time in the field, what's occurred is models of behaviour management. In other words, ways of understanding behaviour and skill sets and strategies you can use. The 4 that I've put up here, but there's a few different more. The first one is called antecedents, behaviours and consequences, or the ABC model. Some of you might be aware of that, it's pretty common. That's the major model I'm going to base my information on today, although I will incorporate a little bit from others. The biomedical model is what we've just done at the start. That's understanding behaviour change from a medical point of view, such as how the brain can affect different symptoms, how medications can affect those symptoms, etc. Progressively lowered stress threshold. I really like this model, this idea about understanding behaviour, in that when your brain is affected by an illness, which includes MS, your ability to tolerate stress reduces. You are more prone to overstimulation. You're more prone to be affected by things like busyness and noise. And the last one is unmet needs. Now, when we talk about unmet needs in terms of an understanding why people show their behaviour, I'm not talking about an unmet need like, you know, my dad didn't love me when I was young and I have this unmet deep psychological need to buy whatever. I'm more talking about more primary things, such as an unmet need is that I'm hungry. I have pain. I need to go to the bathroom. I need the air conditioner on because it's too hot. I didn't sleep well last night. I need some sleep. When we talk about unmet needs, even though people might have more complex needs, we're really talking about those things. For people with MS, particularly when their disease is more progressed, they may not be able to communicate them as clearly as they'd like to with you. So therefore, they communicate through their behaviour. Some general concepts to consider with managing behaviours of concern is it's managing behaviour, it's not fixing. If you have a client with MS who has some complex behaviour changes you're trying to help manage, and through your intervention, they're all gone. Either the person had a UTI that's been cured, or you just magically cured their illness. When we talk about managing behaviours of concern, behaviour support, we're talking about reducing the frequency and intensity of the behaviour. So we're trying to reduce how often it happens, and we're trying to reduce how intense that episode is for somebody. You can imagine that if you reduce someone's behaviour from showing aggression 4 days a week to only showing it 2 days a week, that is a massive win. The reason why I'm hammering this home is don't put pressure on yourself that you're somehow going to use these strategies to completely fix someone's behaviour. It just doesn't work like that. And you're setting yourself up for failure. It requires consistency in a team approach. If you and the care team or your colleagues or you and the family are not on the same page, behaviour management doesn't work very well because it's a consistency of approach. It's a team approach. And it is trial and error. Often you don't know what strategy is going to work. You have to give it a go. You base it on an evidence and a process I'm about to talk about. But also, given the fluctuations for people with MS, a strategy that works one day doesn't work another day. So when we're talking about behaviour strategies, which we'll get into a bit later, we're talking about a toolkit. You have a toolkit of behaviour strategies, something you can reach into and use. The strategies need to be targeted and regularly reviewed because MS is a changing condition, not just the fluctuations day to day, but also over time. Unfortunately, people with MS, they will have decline in their function, decline in their cognition, and change in their behaviour. It's developed for everybody and can be used anywhere. The type of behaviour support I'm talking about today was mainly actually developed by nurses, families, personal care attendants, the people that are on the front line of providing care and support. It's not written by professors or boffins. This is supposed to be practical and you can use it anywhere. In fact, last week I did a talk and a female participant in the audience came up to me and said, "Oh, I've been using the strategies that are working really well." And I said, "Oh, what client group do you work with?" And she said, "My husband." So some of this is also just general good communication. When you look at all the research around the models of behavior, how you do it, behavior support, you can synthesize it into something that we do with lots of other things. What you want to do first is identify the behaviors. So what are the behaviors of concern that you really need to address? If there's lots of them, just focus on a few. Focus on those behaviors that are most distressing. Collect data to identify what the triggers or causes might be. By trigger, I mean the event or something that's happening around that time that causes the behavior. You need to put some strategies in place based on that information, and then you review it. If you imagine this like prescribing a wheelchair, you identify the person's needs, you identify the issues with the existing wheelchair, you put a new wheelchair in place, and then you review whether the wheelchair is working. So we do this type of modeling, we do this clinically a lot. So the first thing to talk about, which is where you might be saying, well, duh, Luke, but I'm going to ask you now, what is a behavior of concern? Because there's a difference between a behavior of concern and weird behavior. A behavior of concern is a behavior that causes distress for you, distress for the person with MS, or distress for their family. Doesn't matter, as long as there's distress associated with it. Why I say to do this is there's also weird behaviors. I once worked with an elder man with MS who had delusions, and his delusions were that he had a fairy godmother type figure who used to take care of him. Now, even though technically that's a delusion and it's weird, it wasn't causing him any distress. And once us as a team learned what it was, it didn't cause us distress. So we didn't do any behavior support for that delusion because it wasn't distressing to him. In fact, it was quite comforting. So you need to differentiate between what a behavior of concern is and what weird or strange behavior might be. So when we try and understand the triggers for behaviors, the causes of behavior change, this is a bit of a model you can consider. The first is brain change, which we've already talked about. The second is premorbid personality, which is someone's personality before they were sick. As I said, I have eccentricities in my personality. So we don't want to pathologize that too much. But if you understand the person before they got MS, you can then understand what's changed. And there is a phenomena in progressive neurological disease where someone's existing personality traits, particularly the negative ones, can increase. We call this disinhibition. And the reason why it's negative traits, which is really interesting rather than really positive traits, is because negative traits or negative behaviors are the ones that we control. I know through my socialization is that it's rude to yell at people. So I'm someone who hasn't really yelled much in the past. But I control that. My frontal lobe in particular suppresses my desire sometimes to yell, particularly during road rage situations. So sometimes it's the negative traits and sort of behaviors that increase because the control is gone of those traits. Personal history is incredibly important. The number one cognitive ability that people with MS retain for most of their illness journey is long-term memory. So if you don't really know the person before they became unwell or in the earlier stages of their illness, then you don't really know the person. It's very useful to know about their personal history, the things that make us, because that influences our behavior. Our hobbies, our jobs, our families, our religions, our spirituality, our sexual preferences, all these things make us who we are. And it's really difficult to do constructive behavior support if you don't know those things. Medical and mental health is incredibly important. People with MS, particularly when they have continence issues and maybe have a catheter or pads, are at increased risk of urinary tract infection. They're at increased risk of impacted bowel. They're at increased risk of all sorts of things. And when someone's behavior changes quickly, so if one day they're really calm and settled and the next day they're really aggressive, it's usually not MS that's doing that. It's usually that there's a secondary medical cause. And looking at their medical history or their mental health history and understanding what they can be prone to can be really useful because you can treat it quickly and then often their behavior improves. We know that people with MS, and I know that you guys will know this, are much more prone to fatigue. But with the fatigue, you often see it after the event. So if they've had a really big day or they've had lots of outings or lots of interactions, the fatigue is often the next day or that night. So it's important to understand how fatigue plays a role, particularly in things like irritability and apathy. Environment is not just our built environment, it's also the noise in our environment. I mentioned before that people with MS can be much more prone to overstimulation. And the thing that I always come back to is heat. We know that hot days for people with MS can be draining, can be fatiguing, can really affect them. So when I used to work predominantly in MS, although I work in much broader areas now, I always knew I was going to get many more calls on hot days. The last one is interaction with others. That's us. Often the trigger for behaviour of concern is us. Not just how we communicate, not just what we say, but often how we look. I didn't put it on a poll because it's a bit controversial, but I'm going to ask you to think about it. If you went into hospital or you had to go into a care facility, would you want to be showered by a man or a woman? I can tell you that I'd want to be showered by a man. And the reason why is that my personal history is that I played a lot of sports. I'm comfortable being nude with other guys in change rooms. It wouldn't really bother me having a male nurse or personal care attendant shower me. But I associate being naked around women with intimacy. And I can tell you that I'd be really uncomfortable with that. So sometimes the interaction is not just what you say, it's you. It doesn't mean you have to change who you are, but you do need to recognize that it's important that people have a preference. Other things to consider when you're looking at triggers is when does it occur? There's a big difference between a behavior that occurs in the morning compared to a behavior that occurs in the afternoon. Often in the morning it might be because the person's having their daily routine where they're doing all their showering and they might have pain, so therefore it's being triggered when they're doing transfers, etc. It's also important in the afternoon because we are more tired in the afternoon. That's where our circadian rhythm dips. That's why people have siestas in the afternoon. I fall asleep at my computer. So when does it occur is very important. How often does it occur? The behavior is very important too. There's a big difference between a behavior that occurs every day compared to a behavior that occurs on a Thursday afternoon at 3 o'clock. My question is, what the hell is happening at 3 o'clock on a Thursday afternoon? I want to know what's happening. Maybe they're having a visit from a friend they're having an argument with. Maybe that's when they take their weekly medication at that time. Maybe that's when a TV show's on that causes them distress. Where does it occur? That's environment. Who is involved? That's interaction. What happens after tells us, were your strategies useful? Did they work? Did it address the situation or did it make it worse? So when you're looking at what causes behavior, it's important to try and think about it in a structured way, not just from knowing the person and their background, but also what's occurring around them in their environment, who's involved, what time of day. So before we get into strategies, I want to give you an Aesop fable. I work a lot with people who do provide hands-on care, nurses, personal care attendants, and families. And when I used to do these talks, I often used to use quite complicated scientific modelling to try and convince people or give them an idea about how to use behavioural strategies. But I actually find this story is more effective. So I'm going to Australianise this Aesop fable a bit. And basically the story goes that a man is walking along the beach with his jacket on. The wind and the sun have a bet to see who can get the man's jacket off. So the wind goes first and says, I've got this, I'll get his jacket off. He blows some wind and he blows harder and harder and harder, but all the man does is put his jacket on tighter and tighter and tighter. The sun steps in and says, I think I can do it better. And all the sun does is send a bit of warmth, gentle warmth to the man, and the man takes off his jacket. This is an analogy for behaviour support strategies. If you think that you're going to solve the situation by arguing, by convincing, by going round in circles, and I told you to do this, didn't you know, I said you do this, you've got MS. All you're doing is going to cause the person usually to become more defensive and increase their risk of showing a behaviour of concern. But if you think creatively and you think differently, which is what we're going to do now, you can be the sun. So there's two different categories of strategies I want to talk about. The first is proactive strategies. This is where you've done all this detective work and you think you know what the trigger is. So you're going to try and either stop the trigger or reduce the risk of the trigger occurring. You see the lightning bolt, which is the behaviour of concern. On the other side of that is reactive strategies, which is where we live most of the time. Most of the time when we're using behavioural strategies, it's because the bomb's gone off, the behaviour's occurred, the situation's occurred, and you're thinking, what the hell am I going to do now? So let's start with the strategies we try and do to reduce the risk of a behaviour of concern occurring. Excuse me. The first is trying to get an understanding of the person's cognitive function. I'm a neuropsychologist. I'm in a privileged position where I do very in-depth investigations of cognitive function. I think, Nicola, you said before that there will be actually talks on cognitive function in MS, is that right?
Yeah, we run a webinar on understanding cognition and behaviour
Perfect.
change.
So you're going to have that as part of this. If you are going to do a cognitive screen, if you're qualified to do a cognitive screen and you don't have time to engage a neuropsychologist, depending on the person's motor functioning, try to avoid the mini mental status examination. The mini mental really only measures memory, and what you'll learn is that memory can be quite preserved for people with MS. The one that I recommend, if the person's physical functioning is not too bad, is called the MOCA. That's the Montreal Cognitive Assessment. You can actually look that up, although don't do it right now. It's free to download. It's in different languages and it's in different versions, so you can do it within a short period of time on a few occasions without practice effects. It's wonderful. So if you are going to do a short cognitive screen, my strong recommendation, depending on the person's motor functioning and sensory functioning, is the Montreal Cognitive Assessment, not the mini mental. But what you can also look at is someone's personal history as well as their cognitive function. As I said before, if I don't like certain environments, and you know that, try not to put me in certain environments. For someone who maybe their premorbid personality is they were more shy, maybe a bit more introverted, then you may not want to be providing therapy in a large space with lots of people. Knowing their personal history can be really important. From people for the LGBTI community, sometimes they will be more comfortable in environments that are more LGBTI friendly. Medical and mental health history is important because putting medical management in place to reduce the risks of common ailments that someone has, like urinary tract infections, like skin tears, like pain, can reduce the risk of a behaviour of concern happening. Sensory abilities are really important to consider as well. We know this is often an issue for people with MS. It's interesting, I was working with a client with MS who was showing behaviours of concern at night time, which can occur just in and of themselves. But on investigating, we realised that this person's vision had definitely changed with MS, and they couldn't see things at night time. So therefore, they were more distressed at night time. As soon as we put some very cheap lighting in the hallway, guess what? The behaviours of concern reduced. Interaction, some of the strategies you can use is rapport building. People with MS may have difficulty adjusting to and accepting new people. So using people that have rapport, that already know them, in an attempt to try and change their behaviour or address it can be useful. I've actually had GPs write prescriptions for showers before for people with MS because the person with MS had such amazing rapport with their GP. If you're new and you don't have that rapport, consider learning some of their personal history or engage a colleague of yours who knows them well to do some buddying. Someone from Queensland told me once that people in Victoria, which is where I'm based, so the people who are interstate listening to talk might agree, people in Melbourne talk about two things, the football and the weather. So if you start with the football or the weather, you might actually build some rapport. Sometimes a gradual approach is really good. If you have longer therapy sessions with someone with MS, why not just start with 20 minutes for the first session, then build up over time so they get used to you. The other one there you'll see is English as a second language. You might be thinking, well, it's quite straightforward. But what occurs with people with English as a second language is often they will learn conversational English if they haven't had formal training or formal education in English at a surface level. So they'll be able to talk to you about basic stuff. But if you get more complicated than that, often their understanding of English drops away. So you might be interpreting as their problem with comprehension or a behaviour change might actually be the fact that they don't understand you. The environment, we've talked about the level of stimulation. It's important to try and get that right. You can experiment a bit with that. Lighting is incredibly important. The way that lights cast shadows on things can be difficult for people with visual change or perceptual change within their brain. Temperature is key for MS, absolute key. And familiarity of environment is very important too. Unfortunately, for some people with MS, when their disease has progressed for a while, they do require to go to a care facility, whether that's an aged care facility or a disability type place. It's no fluke or coincidence that we try and encourage people to take in possessions that mean something to them in that environment. But as I said before, the space we live in most of the time is when the behaviour of concern has occurred. I'm going to take you through 4 different techniques now, which you can use as an alternative to being the wind. The first is communication. I want to try and give you some take-home messages. All these suggestions are based on research, but I give it names that you can remember, because when someone's being aggressive towards you or saying no to therapy or being sexually inappropriate towards you, which can occur with behavior change as well, what we want to do is be able to grab something quickly in our brain and use it. The first suggestion is talk like a newsreader. This is what I use when we talk about slowing down how fast you're talking and breaking up what you say. Newsreaders are actually trained to communicate with people of different audiences, different backgrounds, different abilities. So newsreaders are hilarious because they talk like this. Today at MS Australia, Luke did a talk on behaviour support. Now, you don't have to use that very strange tone, but what I'm doing is I'm having slightly longer pauses between my messages and not giving too much at one time. The next key is don't expect them to remember. I find it hilarious that when we say to someone, it's time for your appointment, and say, I don't remember. And we say, don't you tell them? Don't you remember I told you? Don't you remember I said 5 minutes ago? Someone with MS is not going to say to you necessarily, look, I'm terribly sorry, I have multiple sclerosis, a condition that affects my hippocampus, which means my memory is not as reliable as it used to be. I'm terribly sorry. If you say to them, don't you remember, it's an accusation. You are blaming them. And ironically, you already know they don't remember because you've just told them they don't. So try and think of another way of saying it. Also try to avoid the tourist effect. Many years ago when I was in Paris, part of the same Canada trip, was that a tourist came in who spoke English and said to the French-speaking waitress at a cafe, I want a coffee. The French-speaking waitress looked at him because she didn't understand English. And the tourists, what they did next is they got louder. I want a coffee. At this stage, we're all quite embarrassed. We're looking over. The French-speaking waitress is quite offended now, looks at him again, saying, I don't understand you. And he goes up to a picture of coffee and points at it and says, I want a coffee. What the tourist is doing is what we often do, is he is confusing what he thinks is a hearing problem for what is a comprehension problem. You're going to learn in one of these webinars that MS can affect literally the way that you understand and take in words. So unless you know they have a hearing impairment, don't assume they do. Rather than getting louder, think about how you might say it differently. Try not to argue or rely on their insight. As I said, for some people with MS, they may have no insight into their condition, or it may be impaired, their insight. The importance of smiling. As I said before, the one emotion that people with MS retain is their understanding of happy emotion and how you show it on your face. So think about that 5-second check-in. The next one I'm going to talk about is, can you say it differently? And we're actually going to do an exercise today, which I'm going to ask you to try and reframe and say things differently. The next step is reassurance. What occurs for people with MS is often they might be distressed by something. They might have had a stressful day like we've all had. They might be upset or sad about something. And what can occur is we go into clinical mode. We walk in the room and we say, my name's Luke, I'm a neuropsychologist. I'm going to see you for the next 3 or 4 hours. This is referred by Dr. blah, 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 blah. But the whole time, I'm not recognizing the fact that they are showing me through their emotions. Your social cognition, sometimes unlike for people with MS, should be working pretty well. And therefore, if you think they're showing an emotion, don't leave it as the elephant in the room. Call it out. So there's 2 ways you can provide reassurance to someone who is upset or agitated. You can do it verbally, and this is the safer way of doing it. You can say to them, I can see you're having a bad day. You look pretty upset. Are you all right? I'm here to help. Because if you're trying to do a therapy session with someone who is feeling really anxious or depressed or agitated, and you don't address this at the start, you're not going to get any therapy done. And in fact, you might spend half your session just listening to them and comforting them, and then half your session doing a therapy. But either way, this is person-centered care. It is about the person more than it is about you. The second is physical reassurance. We've got to be careful with this because physical touch is more dangerous in triggering a behaviour of concern. If you are going to provide physical reassurance, the 2 safe places, we think, from research, are the back of the hand and the back of the shoulder. You will often find with your clients, if they're sitting at a table or in a wheelchair, you will put your hand on their shoulder anyway. And the back of the hand can be comforting, and if they move their hand and they're uncomfortable, your hand flies up. Hugging, even though I know that sometimes health professionals might do this or our clients might hug us, it's more dangerous. Because even though the day before that person may have been calm and settled and hugged you fine, if they've developed a urinary tract infection overnight, they are now agitated, this may become a trigger for their aggression. You've got to be careful with physical reassurance, but address the emotion. You don't have to do complicated counselling, just ask them, talk to them about it. The next one is called validation. I love this approach. What we're doing now is we're separating the person and the condition. We are recognizing that this is a person that has MS. They're not an MS sufferer. And I'm not saying this to try and be overly politically correct, but separating the person and the condition pays them respect, but also reduces your chance of personalizing their behavior and becoming distressed. Can you see things from their reality? Your brain is the thing that allows you to understand reality. For someone with MS, the way that they understand their world and what's going on for them might be different to how you see it or how their family sees it. But you're not going to convince them otherwise most of the time. So therefore, if you know the person, if you've used that pie chart I showed before to think about their personal history, what they were like before they got sick, how MS has affected them, you might be able to then start making suggestions or framing things in a different way. So what we're really talking about now is, where is the middle ground? Rather than convincing them, is there a reason you can give them that's going to be meaningful to them? And you can be creative with your responses. Often families will say, well, I'm just telling them white lies. But it's important to recognize that if you know the person well enough, they may not be seeing reality the same way you are. So when you're saying to them, you need to use a four-wheel frame because you can't walk properly, they already may think you're lying because their brain doesn't allow them to understand that situation or reality very well. You can be creative with your response. Obviously, we're not going to lie overtly to them. What always strikes me is someone with MS I was working with who did have a delusion and believed that nurses were trying to poison them. So this is how I used validation. I didn't say to them, yes, the nurses are trying to poison you. That would have scared them. I didn't say to them, no, no one's trying to poison you, you've got a delusion. I tried to look at their medical file. I spoke to them, I talked to their family, and then I tried to put myself in their shoes. So I thought, if I think someone's trying to poison me, what would I want to hear? So I said to them, I'm really sorry that you think the nurses are trying to poison you. If that was me, I'd be really scared. So I've just used some reassurance there. Tell you what I'm going to do. I'm going to talk to the doctor and the nurses, and we are going to do a full-scale, in-depth medication review, looking for interactions within your medications and reduce the risk of poisoning. I'm going to make this the #1 priority for your treating staff. That's what I would want to hear. Now, when I went and saw the doctors and nurses, did I say to them, we're going to need to do a full in-depth medication review? No, because we all know this is a delusion. What I did say to them was, this is the strategy we're using. If she asks you, this is the way we're reassuring her, because that's what she wants to hear. And I can't shift her delusion because it's brain dysfunction that's causing it. So using this information in the last little while that we've got, I'm going to ask you to try and reframe or think differently about how you're going to communicate, how you're going to try and convince someone. I'm going to use a couple of examples, and what you're going to see firstly on the top left of the screen in the speech bubble is an unsuccessful request, something that doesn't work. Then I'm going to ask you, can you think of it differently based on what we've been talking about? There's no right or wrong answers with this. I just want you to start thinking creatively, thinking differently, thinking like behavior support. And then I'm going to ask you to try and reframe the question. I'm going to give you an example of what I might do, but you might have your own suggestions. Either way, that's fantastic. So here's the first request. You need to attend respite because your wife is exhausted. I love this one. The reason why this sort of suggestion doesn't work is it's you need, which is a logical instruction. It's the wind. You need to, you should, don't you remember? Also, it's relying on insight, that the person actually understands the fact they need to attend respite. If you've got to this conversation, it's unlikely the person understands they need respite because you wouldn't be saying this to them. Also, they need to understand the fact that because they have MS and the burden of disability that causes for them is then making their wife exhausted. You need to piece together all of these things. So, can you say it differently? This is what I might say. And I'm basing this on the fact that I know the person's background. I understand that I can use their long-term memory because it's something that they can access quite well and something that's meaningful to them. It's a validation approach. I have found a great local social club for people who like whatever he likes. Football, fishing, dirt bikes, whatever, doesn't matter. Because what I'm then going to say to the respite facility is I have told them that you have an interest group that is interested about dirt bikes. Can you just, on your iPad, get some dirt bike videos that you can look at when he comes in? They would love to meet you. So this is no longer about the wife. I have a bunch of people who have the same set interests who want to meet you. I haven't even used the word respite. I haven't used the word facility. I haven't used someone's visiting your home from the local council. This is what I think might be meaningful to that person. Now, this may not work, but in my toolkit, I've got 2 or 3 other things from all the data I've been gathering that I'm going to use. Hope that makes sense. Let's try another one. You need to do your exercises, otherwise your mobility won't improve. You need to do your exercises, otherwise your mobility won't improve. We're relying on cognitive function here the person may not have. Insight. How can you say it differently? Why do you exercise? I often think this. I think to myself, why do I do things? I hear you really enjoy going to the football. I'm going to do some exercises with you to help you get up the stairs at the MCG. Now, this is a true story. This gentleman loved the Collingwood Football Club, and he loved going to football, which he was no longer able to do easily. So on the stairs that the OT and the physio were using, we put MCG in the sign. We also rang the Collingwood Football Club, who were great, and we got a letter from Scott Pendlebury, which was encouraging this man to do his rehab so that he could come and watch the Collingwood Football Club. It's meaningful to him, and guess what? It worked. So this stuff can be powerful. Like, trust me, if you do this once and it works, you will be converted. The last thing we talk about is distraction. Once you've gone through this process, is that we really want to get someone's mind away from whatever is bothering them, particularly if we're getting to that cycle of you need to, you should. So distract with an activity or a conversation. But the activity or conversation needs to be meaningful. Once again, you're engaging their long-term memory, engaging their familiar interests. So their personal history may provide hints. Coming back to the theme that Melburnians only talk about football and weather, I'm a Melbourne Demons supporter. I have been since I was born. I had no choice in it. So if you talk to me about the Melbourne Demons, if you show me videos of their games, although we haven't won that many, you will distract me. If you say to me, we're going to do some scrapbooking, I may throw myself off the edge of a cliff. So think about that personal history. Start and leave strategies is recognizing that as therapists, as clinicians, we can't be there all the time. So maybe you can start something with them and then distract them, such as putting on some music, putting on a video, giving them a magazine, etc. So you can see, guys, that with this approach, there's a theory. I've only given you really the tip of the iceberg, but I'm hoping that I've stimulated your interest. Just to giving you some contact details for me, I do have a website. I'm a little uncomfortable with it because it has a horrible photo, which you saw at the start. But the reason why I did that is that when I provide services, people wanted a pamphlet. They wanted to know more about me. They wanted to know about me so they were comfortable. It's a way of building rapport. So I just did a website. I have an email address. If you want to shoot me any emails, I work privately in the community. I work in Melbourne. If you want to refer anyone to me for an assessment or you want to talk about someone, please do. And my mobile phone number is at the bottom. With that phone number, what I'd ask is you don't give it to your clients, simply because I'm not a medical professional. And sometimes people confuse neuropsychology, my clients do, with medical professionals. And I have had calls at 10 o'clock at night with people with a medical emergency, and I said, all I do is give you blocks to put together to measure your visual-constructional skill. You need to call a doctor. So I'm happy for you to have my phone number if you've got any questions for me, but just don't give it to clients at this point. And there's the reference list you can have a look through.
Good. Thank you very much, Luke. A host of information there. Really, really fascinating. Lots of tips to take away. I do have a couple of questions that people have asked.
Yeah, please do. One
was just briefly about a recommendation for the type of lighting that might be appropriate for people.
So fortunately, I'm a neuropsychologist who knows the edge of my expertise. And what I can do is talk about general themes, but my suggestion would be you probably need to talk to someone who actually knew more about lighting. Occupational therapists, often I talk to, particularly when they have an understanding of progressive neurological diseases. But I'm not sure about within other states and territories, but in Melbourne, there are also, interestingly, architects who do really understand progressive neurological disease well. So sometimes they're good. Other organisations, I'm not sure if MS Australia does, but you might be able to find some on the web. Obviously, don't rely on Dr. Google, who's not a good doctor, but if it's reputable information, you might be able to find a bit more.
Great. Okay. Well, we've got some very experienced OTs within here at
Perfect.
MS, so we can refer to them. And a question from Catherine, which was a little bit more about the buddying approach, please.
So buddying is in two ways is really useful. The first is that we learn more from our colleagues than we learn from a book. So I can give you, I've given you references on behaviour support and behaviour change, but talking with a colleague that knows the person well and uses really effective strategies, just talking with them, watching how they work with the person, observing what they do is really useful. But also humans, once again, those biases we have in our brain are very concrete. So let's say that Nicola is the consulting therapist and I'm new. If Nicola introduces me and I spend some time with Nicola and then she hands over to me in front of the client's going to simply go, I like Nicola, Nicola trusts Luke, I like Luke. And often what I'll do is actually, before I even send anyone, I will not only talk to families and say, can you give me some ins in terms of their long-term memory? I will say to them, can you introduce me?
Okay, great.
Sometimes it's difficult from a management point of view in that we are all time poor, but if you can frame it in terms of behaviour support strategies, in the long run, something that will reduce the risk of behaviours of concern occurring. In most situations, I find managers and service to be pretty amenable, particularly if you really only need a buddy for 1 or 2 shifts.
Okay, that's great. A couple of other very brief questions come in. Alexandra's asked, do you do any behavioural support around spina bifida?
The short answer is, to be honest with you, I don't have a lot of experience in working with people with spina bifida. But what I would say it's really important with behaviour support is that you're actually supporting the behaviour more than you're supporting the illness, the condition, the disease, or whatever it is. So impulsivity, whatever it's caused by, is still impulsivity. So all of these concepts I'm talking to, regardless of the client's condition, if they're showing behaviours of concern, the theory, the strategies, the models, it all applies. You'll notice from the research that I was really only able to find one scientific study that explored how effective behaviour support was for carers of people with MS, which is a bit disturbing, to be honest. But at the same time, when you look at other conditions like motor neurone disease, progressive neurological diseases that affect older people like Parkinson's disease and other forms of dementing illnesses, it's the same stuff.
I was thinking that as you were talking, Luke, that you referenced MS a lot, but it was very applicable. Your strategies were very applicable.
You can use this in traumatic brain injury. You can use it.
Strokes.
What I would caution about is in the autism area, the autism spectrum field, there are some more specific strategies and techniques that are used in that area, but still some of this stuff would apply.
Great. Okay, fantastic. Well, I'm just going to finish off and just do a couple of very brief slides, just to remind you of the services that MS offers. We've got education and we've got expert advice available through MS Connect. MS Connect is our gateway to a whole host of practitioners, social workers, nurse advisors, continence nurses, etc. And I'll give you MS Connect's number shortly. We have the MS Practice series of journals, and you can access them through the web link there. We are a registered NDIS provider, providing different services in different locations. And here's a list of what we can do, and we provide support coordination. So if your clients do have an NDIS plan and you feel we'd be an appropriate choice for support coordination, please do get in touch with us via the MS Connect number here. We've got ebooks that are available to you if you've signed up for a webinar. Here's the username and the password, and here's your link, and you can download an ebook. We also have webinar recordings on a range of subjects, including the one that Luke mentioned on understanding cognition and behaviour change, which you can purchase through our MS shop. So thank you for joining us today. We really appreciate your time and your support. Here's our MS Connect number, which you can call Monday to Friday with any queries. And if you could stay on after this webinar and complete a very short survey, that would be really appreciated. So thanks for your time, and I look forward to seeing you at our next webinar.